Today we are pleased to welcome Dr. Angela Malik, a very special guest from Abu Dhabi. Dr. Malik is a graduate of the University of Waterloo, the optometry program in 1991, practiced both in Canada and abroad. She is a former chief of the optometry department at King Khalid Eye Specialist Hospital and currently practices in a senior clinical role at the Cleveland Clinic Hospital's Eye Institute, Abu Dhabi, where she has established contact lens and low vision clinic. And today she will be sharing with us her expert opinion on the update of contact lenses. With that, I ask that you give a full attention to Dr. Malik and help me in welcoming her to the stage. Dr. Malik.
Thank you so much, Dr. Khalid, and for your kind invitation and for having me present today and join you all. It's been a pleasure being here back in Riyadh again, except for the traffic. It's been lovely, and teaching the residents is always wonderful. As you know, I'm currently practicing at the Cleveland Clinic in Abu Dhabi. I work with 8 ophthalmologists, some of them you might be familiar with. Today, the subject of my presentation is clinical applications and updates of contact lenses. I have been fitting contact lenses and teaching others how to do so for about 20 years, 2 of those right here at KCASH back in 2000. I'm going to share with you today a deeper insight into an area of ophthalmology that I am quite passionate about. By the end of this presentation, you should be familiar with the concepts of fitting contact lenses, be able to diagnose contact lens related issues, be updated on what is new, and finally, you should be able to confidently and successfully offer contact lens advice to your patients. Does anyone here look familiar? Prior to leaving a few days ago, I rounded up some old KCASH alumni and took a photo. I'm sure you recognize some of these people. Dr. Imad Aboud, Khalid, who is an ultrasound technician, myself, Dr. Sam Navone, who worked here over 20 years ago, Dr. Nicola Ghazi, and Keith Wilkin, who is an orthoptist that worked here. So the Cleveland Clinic is a 365-bed hospital that was recently opened in March of 2015. Its Eye Institute is located within the ambulatory clinic. We have 5 centers of excellence. The Eye Institute was the first to open, and currently it is the busiest. So let's begin with a few interesting statistics about contact lenses. So 50% of contact lens wearers fall between the age of 25 and 44. Most are soft lens users, and 2/3 are females. Daily disposables now account for 40% of the worldwide sales. The largest market increase has been in dailies and multifocals. Patients in their 30s tend to be at the peak of wear, but that drops off quite rapidly after 40. The reason for this being contact lens discomfort and presbyopia. Examination of the distribution chart of contact lenses shows that silicone hydrogel lenses command the largest share of the market right now. I wanted to give you a brief history of contact lenses. So back in 1508, Leonardo da Vinci developed a book called The Codex of the Eye. He proposed that we could alter corneal power by submerging your head in a bowl of water. It wasn't until 350 years later that German ophthalmologist Hick used this concept to develop contact lenses. He invented the first contact lens to be tolerated. It was a glass lens that he actually fit on himself. The biggest event in contact lens history was when a Czechoslovakian chemist combined plastic with water to create a hydrogel material. This led to the first FDA-approved contact lens in 1971 by Bausch & Lomb. I wanted to give you some perspective, and although contact lenses were originally conceived in the 16th century, most of the developments have just occurred in the last 40 years. So this timeline gives you some highlights. In 1987, we had a monthly disposable lens. In 1995, we had daily disposables. 1998, silicone hydrogel lenses. 2001, 30-day extended wear lens. And most recently, second generation hybrid lenses. Contact lenses can be subdivided into 2 categories, soft lenses and hard lenses. And I'm going to go through each category and give you a brief overview. So we'll begin with soft lenses. Spherical lenses are just your standard everyday lens. They're available monthly, bi-weekly, extended wear, 7 days, 30 days, and dailies. A toric lens is a soft contact lens that corrects for astigmatism. A few interesting points to note about a toric lens is that it's prism ballasted, which means it has a weight on it so that it rotates into the correct position. It's a bit thicker, inferior and superiorly, so that the lids can control stabilization. It has a slightly larger diameter than a soft lens, and it has some markings on it, horizontal or vertical, so that the fitter can assess rotation. Soft contact lenses can also be used to correct presbyopia. The most popular method right now is a multifocal presbyopic contact lens, followed by monovision, where you correct the dominant eye for distance and the non-dominant eye for reading. And then least favorable technique is to correct both eyes for distance and to use reading glasses. Soft contact lenses are available in tinted or prosthetic forms. These are custom designed lenses for corneas scarred by trauma or pathology. The intention is to match the appearance of the unaffected eye. Soft contact lenses can also be used as a bandage. There's a multitude of indications, from exposure keratitis to entropion, or as we can see here in these examples, epithelial defect and a leaky bleb. A piggyback lens is a soft lens that's placed under a hard lens. This is a dual lens system, and some important points to note is that both of these lenses must be permeable to oxygen because of that dual lens system. The other thing that can happen is that sometimes when you have a prescription in the RGP lens that's quite large, that RGP lens can be heavy and it can decenter slightly inferiorly. Just like a pair of glasses, the stronger the prescription is, the thicker or the heavier the lens is going to be. In such a case, you can actually suggest to the patient to split the power between the soft lens and the hard lens to decrease the weight of that hard lens. So in the category of hard lenses, we have rigid gas permeable lenses. These correct mild to severe regular and irregular astigmatism. We have hybrid lenses, which are a combination lens where there's an RGP center that provides superior optics and a soft skirt to provide comfort and centration. These are good lenses for patients who cannot tolerate an RGP lens. And then we have a scleral lens. This is available in a mini scleral or a scleral design, depending on the diameter. It can correct severe corneal irregularity, but it also can be used in therapeutic management of ocular surface disease. There's minimal movement, and so there's a fluid reservoir under this lens. That fluid reservoir can mask the astigmatism, but it also can act as a liquid bandage to continuously bathe the anterior ocular surface. So we've gone through the types of hard and soft lenses. Now, when do we fit them, and what kind do we use? So what are some indications for soft contact lenses? Well, generally, refractive error. Most standard lenses come +6 to -10, and about up to a 2.75 diopter cylindrical correction. We can see that the axis is usually available only in 10-degree steps, but you can order pretty much anything you want through a custom lens. The most important point is that when you have patients with high astigmatism, they are very sensitive to rotational changes in their astigmatism correction. So this is why these custom lenses are available not in 10-degree steps, but they can actually be available in 1-degree steps. Soft lenses can be used to fit for presbyopia, and as I mentioned before, a multifocal design is the most popular design right now, and it's actually a modified multifocal design. What does this mean? It means that for the dominant eye, we fit a multifocal with a center distance and a near periphery, and for the non-dominant eye, we fit a near center and a distance periphery. We can use soft lenses to fit aphakia. Aphakia due to congenital cataracts is the most frequent indication for fitting pediatric contact lenses. We know that aphakics have spectacle magnification somewhere between 20 to 30%. Infants usually wear these contacts for 7 days at a time, so you want to make sure that the contact lens that the infant is wearing is extended wear and has a high oxygen permeability. This lens should be replaced every 3 to 6 months. We have cosmetic lenses, and they can come in the form of just enhancement of the color of your eye, but they also come in the form of a prosthetic lens, which we talked about previously. With a prosthetic lens, we can have them hand-painted, or they can be specified with opaque tints, and you can specify not only the iris diameter, but the pupil size and the pupil color. What does that mean? Well, we can have a clear pupil, or we can have a black pupil. So in a case where you have a patient with a completely opacified cornea, if you have a clear pupil, their eye is still going to look a little bit odd. If that patient has a very poor acuity, you can fit them with the black pupil, and they won't notice any loss of acuity, and cosmetically it will look more pleasing. Another indication for soft contact lenses is amblyoptic control. So this is very good for deep amblyopia when patching is unsuccessful. We call this a non-traditional occlusion therapy. We create a custom lens, and there are some risks and some benefits to this. The risk being infection, and that a child could rub the contact lens out. The benefit is that you probably have better compliance because it's more cosmetically accepting. We can use a soft lens as an RGP carrier. This is essentially a piggyback lens. It improves centration and comfort. You can fit that soft lens as a daily lens, or you can fit it as a bi-weekly lens. My preference is a daily lens, and that's because if you have two different lenses that you have to clean separately, the patient is not going to be very compliant. If they have to only clean one lens, they can throw the other one away. Typically, we're fitting these piggyback or carrier lenses with patients who have keratoconus. As you can see from the topography, most often not, there is a steeper area inferiorly. If we fit the patient with an RGP lens, that contact lens will want to sit over the apex of the cone. When it does this, it causes some lid interaction and discomfort. By placing a soft contact lens under the hard contact lens, it raises that contact lens up, provides better optics, it gives the patient better comfort, and overall they're much more satisfied. If you have a patient who is very intolerant to contact lenses, hard contact lenses, and they are considering surgery as an option, this may be something that you might want to use as a trick, as an interim solution prior to considering surgery. Another indication for soft contact lenses is to correct lenticular astigmatism. So in this example, we have a patient that has very low corneal astigmatism, but in their spectacle prescription, it shows that they have a more moderate amount of astigmatism. The total astigmatism is 3 diopters, but the total corneal astigmatism is only 0.5 diopters. We know that RGP lenses correct corneal astigmatism. So in this particular case, the RGP lens wouldn't really benefit that patient. And if a patient was given a choice between wearing an RGP toric lens or a soft toric lens, they would definitely choose a soft toric lens. We can use soft lenses as bandage or therapeutic lenses. They come in powers of plano, plus or minus 50. If you have a busy practice, you should probably have a number of these types of contact lenses in varying base curves. Based on the indication, I have given you some examples of lens types suggested for each use. So for example, with a corneal abrasion or an epithelial defect, a patient may be in a contact lens for about 7 days. So you need a 7-day extended wear lens. However, if you have somebody with entropion who might be waiting for surgery, they might be in that lens a lot longer to prevent any kind of corneal scarring. So for those types of patients, you're looking at more like a 30-day lens. So this table goes through varying types and what I would recommend for each type of indication. What are the indications for a hard contact lens? Well, keratoconus, post-graft, post-RK, LASIK-induced ectasia, irregular astigmatism, high regular corneal astigmatism, myopic control, management of ocular surface disease. Depending on the lens type of hard lens, diameters and vaults vary. So RGPs align with the cornea. Hybrids and sclerals vault the cornea by about 100 to 200 microns. What are the contraindications for fitting hard and soft contact lenses? Well, mental incapacity, low motivation, chronic blepharitis or meibomian gland dysfunction, corneal dystrophies, moderate and severe allergic conjunctivitis. When are contacts preferred over spectacles? Anisometropia, because of image size difference. Unilateral aphakia, which is essentially anisometropia. Moderate to severe keratoconus, when the spectacle prescription, the best corrected spectacle correction is worse than 20/40. Irregular astigmatism, and high myopia because of minification and loss of peripheral vision. These are the parameters that define both soft and hard contact lenses. There are only two parameters that are not consistent between the two types of contact lenses. Those are the coefficient of friction and water content. To have a better understanding of these parameters, let's review them each individually. So what is the base curve? The base curve is the main parameter of any contact lens. It's the curvature of the back surface of the contact lens. In addition to base curve, which corresponds to the central part of the lens, we also have something called a peripheral curve, which corresponds to the edge of the lens, which we'll discuss in a little bit. Power, so basically use spectacle power to calculate a contact lens prescription, but if the prescription is over plus or minus 4, we must vertex that power back to the corneal plane. So for example, if you have a spectacle prescription of minus 650, using a vertex conversion table, we know that the contact lens prescription is minus 6. So the key here is that when you have a myopic patient, their contact lens prescription is going to be less myopic. When you have a hyperopic patient that wears spectacles, their contact lens is going to be higher in prescription. Diameter, another parameter for fitting contact lenses. It's based on the iris diameter. So generally, I would say that with diameter of a soft lens, it's about 2 to 3 millimeters larger than the iris diameter. With a hard lens or an RGP lens, we're talking 2 to 3 millimeters smaller than the iris diameter. Hybrids are the larger and sclerals are the largest. Most modern lens designs incorporate silicone into their soft and their hard lenses because of its high oxygen permeability. This lens material improves end-of-day comfort and hypoxic-related complications. Most contact lenses will have a visibility tint. In a soft lens, this allows the patient to see that contact lens, but in a hard lens, it's more critical because a hard lens does not conform to the shape of the cornea. So if you mix up the hard lenses, it can be an issue. So with hard lenses, we do one of two things. We dot the right lens, and you can maybe see that small dot over here on the right-hand corner, or preferably, what the patients prefer here is to have the lenses made with two different colors. In North America, when we have patients that have light iris coloration, this may not work because sometimes those two different colors may alter that coloration of their iris. Here in the Gulf, where most patients have sort of darker brown eyes, this does not play a role. Contact lens fitting parameters, center thickness. So the center thickness represents the thickness of the geometric center of the lens. Just like a pair of spectacles, a plus lens is going to be thicker in the center, and a minus lens is going to be thicker in the periphery. We want the lens to be as thin as possible to improve comfort and to decrease lens awareness. If it's too thin, like an RGP lens, it could cause flexure and it could induce some irregular astigmatism. And with a soft lens, if it's too thin, it could cause some fragility or difficulties with insertion and removal. The optic zone diameter is actually the portion of the contact lens where all the power lies. We want it to be fairly large and larger than the pupil diameter. If it's not, and the pupil dilates beyond the zone where the power is, you are going to have issues with halos and glare. Water content of the lens material enables oxygen to permeate the lens. Higher water content lenses are more prone to dehydration. In the past, water content was a very important factor for contact lenses, but since the addition of silicone being a highly permeable material, we can actually make lenses with lower water contents now. Wetting angle defines the ability of moisture to spread evenly over a surface. It is measured by the angle formed on the surface of a contact lens material when a droplet of water is placed on that surface. A large wetting angle is important to maintain hydration of the lens. Transmissibility. Transmissibility is the ability of oxygen to pass through a contact lens based on the thickness of that contact lens. Higher dK over T, which stands for transmissibility materials, decrease the rate of hypoxia-related complications. Most hard contacts and soft contacts lenses now have dK over T values of greater than 100. This graph shows you that dK over T values vary depending on if it's a plus or a minus lens. Manufacturers always quote dK over T values for minus lenses, but this can be misleading because plus lenses are quite thick in the center and will have a lower dK over T value. Modulus. This is a new and upcoming word. The modulus of a lens material is the resistance to it being deformed under tension. Higher modulus equals greater stiffness, and it's associated with better handling, insertion, and removal. And we can see that various different contact lenses have varying degrees of modulus. One of the most important factors is coefficient of friction. It equals the lubricity of the surface of a contact lens. A lower coefficient of friction helps to keep the lens feeling smooth, so there's less friction between the eyelid and the contact lens. Studies now show that coefficient of friction is becoming the most important property contributing to end-of-day contact lens comfort. The most comfortable lenses available in the market today try to mimic the coefficient of friction of the cornea, which is around 0.015. And as we can see from this graph, the most comfortable lenses have the lowest coefficient of friction. So what is the ideal contact lens? An ideal contact lens has a large wetting angle, so it will be moist. It has a high modulus, so it's durable and easy to handle. It has a high dK over T value, so that there's a lot of oxygen getting to the cornea. It has a moderate water content, so it doesn't dehydrate. It has a low coefficient of friction, so that it's smooth as the eyelid runs across it. And it has decreased lens awareness caused by a thinner center thickness. So how do we fit a soft contact lens? Well, there are three basic parameters: base curve, power, and diameter, and we can fit this contact lens imperially. The base curve selection is typically done by adding about 1 millimeter to the average K reading. One thing that you should note with soft contact lenses, about 80 to 90% of patients will fall in that medium range of base curve. A very small percentage of patients, typically hyperopes, will have a flatter base curve, and very high myopes will have a steeper base curve. In order to obtain the power, if it's over plus or minus 4, we have to vertex it back to the cornea, and if they have a low amount of cylinder, we have to give them spherocylindrical equivalent. So in this example, the patient has a bit of astigmatism, but not enough to correct, and the spherocylindrical equivalent, just to remind you, is half of the cylinder added to the sphere. The diameter is usually standard. It's anywhere from 14 to 14.2, and like I said, it's about 2 to 3 millimeters larger than the diameter of the iris. A soft contact lens is going to move, so you don't want it right at the edge of the limbal margin, because when you blink, you're going to have awareness. So there should be equal coverage, 360 degrees around the lens. So a toric contact lens follows the same basic parameters: base curve, diameter, power, but we also have to include the cylinder and the axis. Individual differences in lid anatomy and tension will cause this lens to rotate. When the lens rotates on the eye, the astigmatism correction does not change, but the axis does. How do we correct for rotation? Well, one way to remember to adjust lens rotation is to use the mnemonic LARS, which means that if the lens is rotating to the left, we add the amount of rotation to the spectacle prescription. If the lens is rotating to the right, we subtract the amount from the spectacle prescription. How do we estimate rotation? You can rotate the beam of the slit lamp and use the built-in protractor to calculate the rotation. So in the first example, there is no rotation, so we don't have to make any adjustment. In the second example, we have rotation to the right, so we need to subtract. In a third example, we have rotation to the left, so we need to add. Here's a flow chart to summarize when we fit a soft contact lens versus a soft toric contact lens. So if the astigmatism is anywhere between 1 and 3 diopters, we are going to fit them with a toric lens. If the astigmatism is 1 diopter or less, we have to consider how much that astigmatism is in relation to their spherical prescription. If it's less than 1/3 of the sphere, then we're able to fit them with a soft spherical lens. If it's greater than that, we should fit them with a toric lens. So here's just a table that gives you the indication of the replacement schedule. So dailies are replaced every day. Disposables are anywhere from 7 to 30 days, sometimes 2 weeks. Frequent replacement are 1 to 3 months, and conventional, which hardly anybody wears anymore, is a year. RGP lenses use diagnostic fitting sets. We have the same basic parameters again, base curve, diameter, power, but we also have to take into consideration something else called edge lift. At the initial fitting, it's advisable to use topical anesthetics to prevent tearing. With a lot of tearing, you won't be able to assess how that contact lens is going to fit. We apply fluorescein to assess the cornea to lens relationship. An alignment fit is ideal for patients with regular astigmatism. If we insert the trial lens and we use fluorescein, we can see that the left diagram indicates an alignment fit. The middle will show you a flat fit, so there's bearing in the central cornea and pooling in the periphery. And the third indicates a steep fit, where you have actual vault of the central apex, sometimes trapping air bubbles. How do we calculate the final lens power of an RGP lens? So we have a trial lens, and in that trial lens there is a certain amount of power. We do an over-refraction, but the over-refraction is done at the spectacle plane. In order to calculate the actual power of an RGP lens, we have to convert the over-refraction at the spectacle plane in the phoropter to the corneal plane, added to the trial lens power, and that gives us the total power for the contact lens. Diameter is usually set by the manufacturer, but it's about 2 to 3 millimeters smaller, and we can adjust it according to the size of the palpebral fissure. Edge lift, this is the other part that we have to be concerned about that we don't have to worry about with soft contact lenses. There's standard edge lift, there's steep edge lift, and there's flat. Edge lift corresponds to the peripheral curve design. We need to adjust it according to the movement and the fluorescein pattern. So in the first example, we can see a very wide band of fluorescein. That has excessive edge lift, and that lens is going to move a lot, and it might actually interact with the lower lid and cause the patient some discomfort. The second example, there is very minimal edge lift. We see a very narrow band of fluorescein. That lens will be tight, it won't move very much, and the patient will complain of discomfort. In the third example, we have very good edge lift, except for one particular area, inferiorly around 6 o'clock. This is usually seen with patients who have that steep inferior cone, where there is a lot of steepness at the lower part of their cornea, which is going to give some asymmetry to the edge lift. So right now, we can actually specify edge lift depending on the area of the contact lens, where we need to adjust it accordingly so it can be quadrant specific, as we say. So in the first picture, you can see where there's excessive edge lift. We've adjusted it just at 6 o'clock to create a more even edge lift throughout the whole periphery of the contact lens. Complex RGP fittings are a little bit more challenging to look at in terms of the fluorescein pattern than a standard RGP fitting. For a keratoconic, which is what you're going to see the bulk of, you're looking for something called three-point touch. Three-point touch means that there's a mild feather touch over the center of the apex, accompanied by 2 other areas of touch at the mid-periphery. Contact lens candidate selection. So who is a good candidate for contact lenses? Well, you have to look at their motivation, their occupation, their previous ocular history, their general healing, such as patients with diabetes or rheumatoid arthritis or autoimmune disease, systemic medications that can cause dry eyes, allergies, pregnancy and menopause, which can cause hormonal changes, and age and responsibility. The CDC reports that 99% of wearers have one habit that can increase the risk of infection. 87% of patients sleep or nap in their contact lenses. 84% shower with their lenses on, and 50% don't comply to the replacement schedule. What are some complications that we see with contact lenses? Well, they are numerous. None of them are really sight-threatening, and when a patient develops a serious complication from a contact lens, they typically don't go back to wearing contact lenses again. So we can have traumatic effects to the contact lens. One thing that you should note is that a contact lens wearer has decreased corneal sensitivity, so it might look a lot worse than the patient is actually complaining about. The other thing that you should know is that when a patient wears a contact lens, it almost acts like a bandage, so they might not even be aware that they have any issues with the surface of their eye. Metabolic or occlusive, usually related to wearing a contact lens that's too tight. Sometimes it can cause an indentation ring, as we see here, or with a scleral lens, if you look really closely at the limbal margin, you can see how the blood vessels sort of are blanched because that lens is too tight. We can have toxic complications. This is usually the result of preservatives in solution, benzalkonium chloride, and sometimes with incomplete neutralization of a hydrogen peroxide system. We can have a hypersensitivity reaction. This is usually caused by deposits on the surface of the lens. Patients don't comply. They don't change their lenses at the proper time. These deposits build up and cause an inflammatory reaction of the eyelid called GPC. We can have hypoxic conditions, and this is usually in the form of neovascularization. It's superficial as opposed to deep that occurs with chronic inflammation. I don't really see a lot of neovascularization anymore because of silicone hydrogel lenses. The only time I do see it now is when we have patients who are wearing a daily wear lens, but they sleep in it. And then we have infective. So as we said before, 50% of patients are non-compliant. Bacteria adhere to the surface of the lens. These pathogens may cross the fragile epithelium damaged by overwear. They cause infiltrates, dry eyes, edema, photophobia, and moderate to severe discomfort. So at the Cleveland Clinic, we use electronic medical records and a system called Epic. One of the ophthalmologists has designed this HPI for contact lenses, so I thought I would share it with you. It's quite good. So, what is new? There are many recent developments in the last 5 years and potential new applications for contact lenses. So there are now smart lenses. So Sensimed Triggerfish has a disposable lens that can monitor IOP fluctuations. The sensors record the microprocessor. That sensor is around his eye, and a microprocessor documents the change over a 24-hour period. Some studies say that fluctuations in IOP may be an important contributor to the risk of glaucoma progression. Alcon and Google have developed another contact lens sensor to measure tear film glucose levels. And there's a third contact lens in the research stages testing a sensor to provide near focusing to an intraocular lens. We have drug-eluting contact lenses. So there's a tear enzyme called lysozyme that causes the gel within this lens to break down. The drug is released into the posterior lens tear film where it has prolonged contact time with the cornea and increases bioavailability. This usually allows drug availability over a 48-hour period. This is particularly useful when drop application is hourly. The cost is much higher than conventional drops, but efficacy and compliance will make this an attractive solution. There are still ongoing in vivo trials with the drug-eluting contact lens. Myopic control. We can use lenses to decrease hyperopic defocus in the periphery of the retina. Using lenses to decrease hyperopic defocus may slow down the progression of axial length changes. These lenses are called MiSight and are similar in design to a multifocal lens. In 2014 study shows that the progression of myopia with these lenses was decreased by 40% per year. Very popular lenses in Asia. They are not FDA approved. What's new in tinted contact lenses? Well, instead of the pixels being put on the surface of the contact lens, new lens designs have pigments that are encapsulated within the lens polymers. Another popular trend in Asia is to increase the size of the iris diameter. They are also called doll eyes, and about 40% of people wearing these contact lenses are actually plano in power, but they're doing it for a cosmetic reason. There is a contact lens camera, and this camera has sensors embedded into the lens. This is designed for the visually impaired. It's another Google project, and the camera, which is embedded into the lens, is there to assist with the visually impaired. Sensors have the ability to detect light, color, and movement. When this contact lens is worn, it would send an audible message to the visually impaired's smartphone to warn them of objects in their field. We have antimicrobial lenses. These are lenses treated with a peptide to impart antibacterial properties in the lens. There are now daily multifocals and daily torics available. 50% of patients who wear contact lenses report dry eye. This lens incorporates PVP, a water-loving polymer, on the surface of the contact lens. It targets digital device users who spend an average of 400 minutes a day between their laptops, phones, and tablets. We can use an OCT to assess apical clearance or vault more accurately than we can with fluorescein. We want to ensure that there's no bearing on the cornea. So if we're
Welcome to Polycom Conference Recorder Playback Service.
The ideal vault of a hybrid, a scleral, or a mini-scleral is somewhere between 1 and 200 microns, and using an OCT allows us to accurately determine that.
Conference recording has started.
So we now have contact lenses that are for oblate corneas. So these are second-generation hybrid lenses launched in 2015. They are great for post-surgical patients, including post-RK, PKP, and ectasia. These patients are extremely difficult to fit because of their oblate corneal profile. Recently, I fit the first patient in the UAE with one of these lenses called an Ultra Health FC hybrid lens. He had a history of 16-cut RK. He had monocular diplopia, glare, difficulties wearing contact lenses and glasses, and very poor vision. He had an extremely flat cornea with mid-peripheral steepening. Just want to go back and show you his K readings. His K readings were 31, 33, so really flat. So these lenses vault or elevate the cornea and have minimal mid-peripheral bearing. They allow for better alignment centrally of oblate corneas and thus improve optics. The patient was very pleased and stated that this was the best vision he had ever obtained post-surgically. Diagnostic lens fittings. We can use diagnostic lens fittings to see if acuity with an RGP is superior to spectacle acuity. This will allow us to predict outcomes of custom wavefront treatments and possibly increase surgical success rate. So at the Cleveland Clinic, we are often seeing patients. We place a hard lens on their eye. We assess if there's an improvement in acuity over best corrected spectacle acuity, and if there is, those patients potentially have the ability to undergo a wavefront treatment to improve their vision. Contact lens assisted collagen cross-linking. So there's a new technique in cross-linking for thin corneas. They use a UV barrier-free soft contact lens that has been soaked in riboflavin. It adds 90 to 110 microns of added thickness. The lenses that we use at the Cleveland Clinic are Bausch & Lomb soft lens and focus dailies, and they must be non-UV blocking for obvious reasons. What's new in contact lens solutions? Well, there's been a lot of new contact lens solutions that were launched in 2005. There is a resurgence of hydrogen peroxide-based systems, and this is because they are preservative-free. And finally, we have a telescopic contact lenses. Telescopic contact lens, it uses aluminum mirrors and light reflection to increase image size. The Scleral Lens provides approximately 2.8 times magnification. It uses blinking to control zoom in combination with a pair of polarized spectacles. To switch between normal and magnified view, the user winks to interrupt the light being reflected from the contact lenses to the glasses. This targets patients with age-related macular degeneration. So in conclusion, lenses have a rich history dating back 500 years. As I've shown you, there's a diversity of lens modalities. The lens market is estimated at about 7.6 globally, and it's growing rapidly. And finally, as we've seen today, current innovations offer the future promise of wider applications other than vision correction. Thank you.
Welcome everyone this afternoon for Grand Rounds, and we're very pleased and honored to have a great guest speaker today. And as we all know, we struggle a lot with infections of various sorts, and we're fortunate to have Darlene Miller, who's the scientific director of the Ocular Microbiological Unit at Bascom Palmer. And Darlene has had a lot of experience with fungal infections, bacterial, viral, and has certainly done the yeoman's work in publishing a lot about how we should handle endophthalmitis, for instance, and what trends we see with infections. So she's going to give us an update talking about where we are with microbiology, but specifically looking at some of the new molecular abilities we have to help sort out what to do with infections. So Darlene, thank you very much.
Oh, thank you, Dr. Craven, for that kind introduction. And I'm very glad to be here to share some of our experience at Bascom Palmer with you, and hopefully you can I can get some experience examples from you also. So today the topic is, the goals are to provide a brief overview of the traditional microbiology techniques that we use, and then, what happened? And then to discuss the integration or the advent of molecular techniques into the ocular microbiology diagnostics. Wrong slide, okay. So, ocular microbiology in general is concerned with the organisms that colonize, invade, infect, and otherwise damage the ocular surface. These are many and can be, as you know, bacterial, viruses, parasites, chlamydia, or chlamydia. Ocular microbiology diagnostics is concerned with defining the most efficient and rapid methods to provide the physician with information on the identity of the microorganisms and how to discriminate between a pathogen and a non-pathogen. So, but what are we looking for? In general, the most common ocular bacteria that we see, at least in the United States, and I think worldwide, you just have to shift the order of the organisms, is Staphylococcus aureus, and that is becoming a major concern in ocular circles due to the increasing rise in methicillin resistance, which makes the organisms, renders the organisms very difficult to manage in that it carries with it multiple co-resistance. Also, Staphylococcus epidermidis is the most common cause of endophthalmitis and increasing cause of keratitis worldwide. Strep pneumoniae, Haemophilus influenza, and Pseudomonas aeruginosus are the most common that the laboratory will report back to you. The most common fungal pathogens you are looking for, or we're trying to define or rule out, include the Fusarium species, Aspergillus species, Curvillari species, and the Candida species. These may differ depending on what region of the world you are. And currently there can be up to 80 or more fungal species infecting the eye, mainly keratitis followed by endophthalmitis. So the common viral infections are the herpes simplex viruses, the enteroviruses, and the adenoviruses called EKC and AHC, as the picture on the left shows, and varicella zoster, cytomegalovirus, HIV, and the papillomaviruses. These are responsible for a lot of viral misery and morbidity and compromised vision throughout the world. The most common parasites, which are probably among the fewest that we see in the microbiology laboratory, includes Toxoplasma, Acanthamoeba, and Microsporidium. Oh, you can't see. I don't know what happened to that one, okay? Oh, and Acanthamoeba. But why are you doing it? Why do you want to use, why would the physician want to use the microbiology laboratory or to culture using traditional methods? Well, there's always changing spectrum of ocular diseases. You want to look at the emergence of new diseases, reemergence of old diseases, introduction of new therapeutic agents like the new antibiotics, the new antivirals, and even new information on the familiar pathogens. And you need to use the laboratory to complement your clinical diagnosis, because in looking at the accuracy of the diagnosis of our physicians in the United States, at least, when looking at microbial keratitis, clinical predictability of an infectious presentation is only 76%. And then when you drill down and look whether it's bacterial, fungal, or amoeba, you see the percentages go down with the cantamoeba, probably more syndromic than any of the other pathogens. Also, you may want to, if the patient is on antibiotics, then the clinical diagnosis and the predictive value of what it's going to be is greatly decreased. And so what is the role of the microbiology laboratory? Well, the microbiology laboratory can help you decide whether or not it's infectious or non-infectious. It can provide a definitive ID, whether it's herpes simplex 1 or herpes simplex 2, help guide on adequate therapy. Would you want to use a fluoroquinolone against MRSA, or would tetracycline or trimethoprim sulfur be the same? Be more efficacious. And then you want to look at the emerging trends in your area. Do you seeing more cantamoeba, more Pseudomonas, or more MRSA? The traditional microbiology methods are using smears, cultures, and then using susceptibility testing to provide a general report for the physician so that he can complement his clinical diagnosis and make a more accurate decision in management of therapy. So the traditional smears include the gram stain, which will help you decide whether your organism is gram-positive, gram-negative, and that can help narrow your spectrum, your selection of antibiotics. We can use the Giemsa stain to look at hyphal elements as well as a cantamoeba cyst, and the Giemsa stain for chlamydia inclusions and or viral inclusions, if you like. The array of culture media is still the basic foundation of the Ocular Microbiology Laboratory. We, we use a variety of media. We can use chocolate to look for fastidious organisms like gonorrhea or Haemophilus. Staph epidermidis grows on almost all media except SAB, and in the middle you see drops from anterior chamber that we just drop directly on the plate in the OR for endophthalmitis. And then, interesting enough, you can see mixed infections with using Sabero to rule out fungal keratitis. There's a variety of other media, but the basics are blood, chocolate, and Sabero. In general, for traditional microbiology techniques, 95% of all bacteria and fungi can be recovered on those three medias. And special media may be needed to rule out acanthamoeba or microsporidia, and sometimes mycobacteria species. And the graph here just shows our initial isolation media. So we minimum specimen use, you can use chocolate and blood. The gram stain or smear in general, this should be smear, correlates with, in our hands, about 88%, but it depends on the quality of the sample. So we look at the samples collected, and the cells and organisms we see in about 2/3 of the cases. So what's new? Well, the traditional flow, as you can see up top, is just a schematic showing you the traditional method. This is in a routine laboratory, but it's the same for ocular. You use blood, chocolate, look at the plate after 24 to 48 hours. You pick a colony, you do sensitivity, The alternative methods now is you send it for DNA sequencing or you send it for other molecular techniques. In general, for routine microbiology, your turnaround time is, for bacteria in general, 18 to 48 hours, depending on the microorganisms. Some microorganisms like strep viridans or P. acnes will take longer. In general, in our hands, fungi, 24 to 72 hours. However, it can take up to 3 weeks for the fungi, depending on which species it is. Viruses, we detect in 24 to 30 days. So the 24 hours is the herpes viruses because they grow more rapidly. The 30 days are the adenoviruses or that causes EKC, or the enteroviruses that causes acute hemorrhagic conjunctivitis. Acanthamoeba, 24 to 72 hours, but 95% of viruses are recovered in 72 hours. Mycobacteria, which is the mycobacteria that's non-tuberculosis, our most common ones are Mycobacteria chelonae, Mycobacteria abscessans. And again, 95% of ours will grow in 3 days, but it can take up to 8 weeks if it's a non-rapid grower. So in general, traditional techniques, what are the advantages and what are the disadvantages? First, the advantage is that you can actually confirm the etiological agent, and that can support your clinical diagnosis. And most of the media supplies are available in common or routine microbiology laboratories. They can help with supply the Ocular Microbiology laboratory if you don't have a separate one. In general, it's pretty cost efficient, and most important for me and probably for epidemiology is that you will have available the isolate for additional studies, including molecular and susceptibility testing. The disadvantage, of course, is that the results depends on the specimen, quality of the specimen. If you take a poor specimen, you submit it, you'll have poor results. It's relatively insensitive with about sensitivity reported between 60 and 80%. It does require skilled personnel, so you do need trained personnel to to run your laboratory, ocular laboratory, wherever you are. You need them trained in microbiology techniques, interpretations, and they need to be kept updated. And it may take up to 1 month to confirm. So, what about molecular techniques? What is the key to molecular detection? In general, for molecular techniques, you need to extract the DNA and then run the PCR. I think I have that reversed. Okay, let's see. Yes, okay. So molecular diagnosis, what is molecular diagnosis? It is the application of molecular biology techniques for the detection, treatment, diagnosis of ocular disease. The role in ophthalmology, we can use it to detect the host pathogen relationship, but more importantly for us, we can use it to identify infectious disease. What is the process? What's going on between your patient and the microorganism? In an Ocular Microbiology Immunology survey in 2012, we did a survey to determine how well or how frequent molecular diagnostics were used in our cornea infectious disease personnel as well as our retina and disease personnel or practitioners. And we had a response of 70%, and we said, how often do you use molecular diagnostic techniques? And you can see in 2012, most of them did not use molecular diagnostics. Some of the reasons for that was difficult, no reference laboratory. They were not well educated on what was available. Among those who did use molecular techniques to help in their clinical practice and support their clinical suspicion, among that group, they used it most frequently to detect and confirm viral infections. And this was from the retina group, or to document viral retinitis. Okay. And the next most frequent one was when they did not know what the microorganism was. It presented atypically. It didn't look like anything they had seen, or the patient had been on long-term antibiotics. This was followed. Toxo was only used less frequently than the chlamydia or mycobacteria, but it's very interesting because we usually bundle our viral and toxo together. Okay. So in 2014, we did a similar result by mail, and we haven't gotten those results totally tabulated yet, but there has been an increase in the percentage of ophthalmologists using molecular diagnostics to complement their clinical suspicion. And again, the greatest group would be the anterior segment, those with uveitis, and cornea are increasingly use it to rule out viral infections and atypical pathogens. How does that work? Well, all of us, whether we are animal, plant, or acanthamoeba, contain unique DNA sequences. Molecular techniques exploit this differences, or this conserved sequence that makes a human and acanthamoeba an acanthamoeba. To use molecular techniques in ophthalmology, you have to be more focused. You have to have a high suspicion of what you think it is or how to rule it out, because you have very small sample, and you can't just take the sample and say, tell me what it is. You have to have a suspicion. So you have to say rule out bacteria, and you have to use a different profile. You use molecular techniques to detect bacteria, which would be pan bacteria 16, which is a 16 RS DNA. If you wanted to detect a fungi, if you had a high suspicion of fungal, you would run or request a 18S DNA sequence. You could do a multiplex PCR to look for free-living amoeba, or a multiplex PCR to detect viral retinitis. So it's a very small sample, and you have to be more focused. But now there's an additional molecular technique called sequencing, or whole genome sequencing, that you can may get an idea by sending that sample and say whole genome sequencing. But that's very expensive and rarely done routinely, even in the molecular diagnostic laboratories. Conventional PCR is you have to have, you extract the DNA, you select primers that will detect that organisms, and the primers is just a short sequence that will attach to the DNA that you think is there, and then during the amplification sample, multiply it 100 to 1,000 times, so that you would be more able to detect it on a gel. So you start with your DNA, you have your primers, it separates in the little primers, a nail to each of the separated DNA. It goes through a 42-cent cycle, replicating the DNA, and then cycle 1 you have 2 copies, and by the end of the cycle you have 32 cycles, or 2 to the 5. And then it's much easier to see on a gel stained with ethylamine bromide. We have used this technique, routine conventional PCR, to detect chlamydia trachomatis in our newborns across South Florida. And we compared it with other conventional techniques, including direct fluorescent antibody. This is our conventional PCR, ELISA, and culture. And you can see by far it is the molecular technique that has the highest positivity rate. And culture actually, among all of these, cultures for chlamydia is much lower. So if you were going to look for chlamydia, it would be advantageous for you to use a molecular diagnostic test. And we even found it in people age 50, confirmed in every chlamydia in every age group, actually, from 1 to about 3 months to, I think the oldest here was 96. The real-time PCR does amplification and identification all in one setting. You don't have to separate the product and run it on a gel. It goes through similar cycles, and it has a threshold. You set a threshold, and if the product goes beyond the threshold, it has a typical curve, what they call a growth curve, and you can say, okay, this is HSV, this is VZV, and at one time. So we like to use real-time PCR because this can occur within 2 hours. Conventional PCR can occur within 2 to 6 hours, but you could have your answer here in about 2 hours. And it uses a fluorescent signal to help specify the microorganism. And this is the technique that's most often used to confirm viral retinitis. With a combination of, you can take the vitreous sample or the AC sample, you can run it for these four are the most common that we do. You can use that to rule out CMV retinitis or VZV retinitis. You can run it on a gel and a little more specific than a conventional. And we illustrated this again using this technique, PCR technique, to identify fungi and acanthamoeba from our corneal isolates. Culture for acanthamoeba 0, using the same sample, but when we use different permutations of our PCR mixture, then we can see it changes. But in every PCR application we were able to identify fungi and acanthamoeba where the load or the productivity in culture was very low. So again, if you think the patient has acanthamoeba or fungi and your laboratory says negative, 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 you could select a scraping or a vitreous or AC sample, send it and specify, I want it to be ran for fungi, and they will run what is called an 18S, or acanthamoeba, which is also an 18S. But you'll get increased detection or sensitivity anywhere from 6 to 14 times that of culture. In summary, why would you want to use, again, PCR versus culture? This is our percent culture positivity rate in 2014, I think. So conjunctiva, culture-wise, it's about 50%. Cornea at about a third, vitreous is about a third. Overall, 35%. But what impacts that is the use of long-term broad-spectrum antibiotics. However, the advantage of using molecular techniques that they can detect even those organisms that are not viable. Okay, so in general, PCR has high sensitivity and specificity. You might also want to consider, because even with the smaller volumes, culture has a threshold of the number of organisms in a specimen. If it's below that threshold, they won't grow. However, with PCR, the advantage is you take a small few colonies and you amplify that DNA until you can detect it. It's very advantageous for identifying microorganisms that may be very difficult to identify or grow in the laboratory, like some viruses. CMV and varicella zoster takes quite a while to grow in our laboratory. We do viral cultures, and in the average days are 21 days for those. But we can get an answer in 2 to 4 hours with PCR. It can also identify genes associated with the host response. So you can say, what's going on here with the host graph, and they can determine whether the interplay and rejection is due to host genes or the interact or the pathogen genes. And it can also, PCR can also detect a variety of antibiotic resistant genes by just looking for the most common ones. So these reasons are all reasons you should consider at least instituting some molecular techniques in the laboratory. Molecular diagnostics can reduce detection time from versus molecular versus traditional time by 25 to 90%. Remember, this is just what it takes. The conventional turnaround times for bacteria, fungi, viruses, Candida, mycobacteria. In general, the greatest advantage for molecular diagnostic would be for viruses and fungi. The advantages of implementing molecular techniques, or the role of molecular techniques in ophthalmology, is to a rapid confirmation of the etiological agent. You have increased sensitivity, you have increased specificity. You can detect new or emerging diseases or pathogens, and probably the molecular techniques, diagnostic techniques in the laboratory is the future. We will always probably have some culturing, but it is molecular diagnostics that is the main focus of molecular or microbiology laboratories worldwide. However, the disadvantages are that right now there are no standards. I mean, there are no standards for implementing a routine practice of molecular diagnostics for viruses or bacteria, because it can be 1 to 3, or it can be very, very different. You don't know what you're looking for, so you don't know what standards to run. There are very, very few commercial kits to look for ocular pathogens. There are a few for herpes and chlamydia and mycobacteria. It's quite expensive, especially compared to conventional techniques in the Ocular Microbiology laboratory. Most importantly, again, for me, is that you don't have the isolate available to do any kind of testing. You don't have the isolate to do anti-susceptibility testing or to do any epidemiological testing. You're just detecting the DNA, the fingerprint, the genomic fingerprint of that organism. So once you do that, you no longer have that to evaluate mainly because you don't have it to evaluate your susceptibility. It requires skilled personnel beyond that for microbiology, and you need to multiplex. You need to put them together and be more focused in your diagnosis. And for here, your clinical suspicion is very important, and you have to make a more focused request to the microbiology laboratory. The next couple of slides will give you an idea of how we can use it to complement our clinical diagnosis and our microbiology reporting to the laboratory. This is actually, I should go. I think it's okay. I have to go back. These eyes are from patients who were involved in an outbreak of vaccine-associated endophthalmitis in 2011 from a compounding company in Miami. There was a total of 12 patients. They presented into our clinic or Bascom Palmer within 2 days after injection, 2 to 3 days after. One of the first ones, July, was injected. They came to us on the 10th, and we isolated strep mitis oralis. And as you can imagine, the issue was it the Avastin, was it Avastin contaminated, or was it actually coming from the patient? A second patient was just here. This is just for demonstrating to show why you would need to have a rapid diagnosis, because this organism rapidly destroys the retina, and some of the patients went to evisceration. So how did we do that? Well, we use our traditional method, of course. We use culture. Traditional method was Vitek 2. We grew it on blood blood agar plates from all patients and from 4 unused syringes, and we found it to be just between a viridans strep group, strep mitis, strep oralis. But we looked at what they call the housekeeping genes of strep viridans to see if we could definitively say that yes, these microorganisms was coming from the Avastin compounded by that company and sent to us. And so we did PCR looking at just the fraction of the organism's genome, and these are called housekeeping genes, those genes that make strep viridans versus Pseudomonas aeruginosa. And what we found was that PCR-wise also, they all were in this strep mitis oralis group, and they was from 86 to 98%. So, and they were from both the Avastin and from the actual AC and VIT cultures that we did. And we compared culture, our in-house Bascom Palmer in-house PCR, and CDC's molecular techniques. So just to compare, all of them identified the organisms as strep viridans group, but the specificity was different and the speciation was different. But more important, in each instance, there was an interocular sample and an Avastin sample that had the same organism. The majority for CDC, they did 3 Avastins, 3 vitreous samples, and they called it this organisms. Our in-house called 2 of the 2 and called the 3rd one this. But the bottom line for interpretation of this is that the PCR was able to confirm unequivocally that the Avastin was contaminated with that organism, and that organism was the one that grew from our AC and or VIT cultures. Another interesting thing is, we are not alone. We have an individual microbiome. As a matter of fact, organisms outnumber our human cells 10 to 1. And so everybody carries around a unique microbiome, and that microbiome determines your susceptibility to chronic disease, acute disease, obesity, and things such as obesity. Okay, let's go. So, okay. When they did the ocular microbiome, they did not do the eye. I'll go back one thing. Again, just to say that you see that we are 10,000 microbes on a healthy person, and this microbial diversity and abundance influence your health and disease. It even impacts your mental health. It's the new paradigm of health and disease. You need a stable microbiome to be healthy. Any disruption in that antibiotics, steroids, will change your health equilibrium. When they did the human microbiome, they did not sample the ocular. They did everything around the eye. They did the nose, the oral cavity, and the hair, but they did not do any studies on the eye. So in 2009, we started a preliminary report on looking at the ocular microbiome to see if changes in the ocular surface organisms, community of organisms, would change their susceptibilities, things such as dry eye, difference in the culture negative endophthalmitis. Okay? So the main purpose was to investigate, again, the diversity and community structure at the ocular surface, and to identify the roles and contribution of that group of organisms to ocular surface health and disease. That is, again, we wanted to see if we could place correlate any ocular diseases with changes in the ocular microbiome, like they have associated with certain systemic diseases, with a difference in the types of organisms in the microbiome, increased ratio of gram positives to actinomycetes. obesity, they're saying that people with reduced ratio of bacteroides to gram-positives are more likely to be obese. Inflammatory bowel disease, larger populations of gram-negative organisms. So the question is, if there's shifts in the ocular microbiome, does that increase patients' susceptibility to dry eye or specific infectious disease? So what we found, we looked at 4 different individuals. We sampled the conjunctiva, did DNA extraction, sent it for pyrosequencing or sequencing. And actually, amazingly, we found more than 221 different species at the ocular surface. The maximum number of species we can culture in the laboratory that we have is about 5. And those have been Staph epi, Corynebacterium, some Strep viridans, Candida. But here, this is some of these we had never heard of, and we still cannot culture. But the most important thing for you to see and confirm is, look, each of these are different. Each of these have a different ocular microbiome. Each in the, males versus females, younger versus older. So you have a different ocular structure, a community of organisms at your ocular surface. Okay, we had some unclassified, but there were 5 major phyla that we found. 12 genera was ubiquitous and constituted what we thought was a core ocular microbiome, and that core included what we can grow in the laboratory: Corynebacterium and Staph epi. Similarly, one of my main interests is acanthamoeba keratitis, AK. Why do some people do better with acanthamoeba keratitis while others do much worse? And so, lo and behold, we knew that acanthamoeba is a Trojan horse, and it harbors many different microorganisms. But more importantly, it disperses these organisms into the environment, and it has been associated with respiratory infections in humans, and also we found in our study that when we looked at the ocular microbiomes of 7 different acanthamoebas, again, you see they were all different, and they involved a variety of microorganisms. Let's see. Okay. Yeah. No matter which group, whether you do traditional or whether you do molecular techniques, all of it is predicated on taking the proper specimen, sample specimen. Everything begins with the sample. Garbage in, garbage out. Okay. For instance, if you were looking for this if you were going to take a viral culture to rule out herpes or varicella from this young man, you would not want to use a swab to collect anything from this encrusted region, this crusted lesion. You want to get any of the lesions that are a blister or has fluid in it, because if you do a swab and send this to the laboratory, you will not get any kind of results. Okay? Again, the quality of the specimen impacts your patient care and outcomes, your therapeutic decisions, your infection control activity, patient's length of stay, total hospital costs, and it can lead to systemic medical errors. It is very important, again, whether you're doing traditional or molecular. Poor quality specimen, poor results, poor outcome. Okay, so now I want audience participation. 3 cases. Culture or PCR? And any guesses as to what these are? Any cornea people, external folks in? All of these are, okay, maybe this will help. All of these are gram-positive asaphas rods. Does that help? Okay. The case Supro is an organism called Suchomarella, and it looks like mycobacteria, it smells like mycobacteria, and if you didn't do molecular techniques, if you just did the gram stain, the acid fast in the laboratory, you would call it a rapid mycobacteria species. Why you need to distinguish between these two is that the susceptibilities are quite different for Suchomarella versus mycobacterium species. We do have a mycobacterium species among the other two. Which would you think it is, B or C? Okay. C is a contact lens where is growing a mycobacterium species. Would you want to culture or would you want to do molecular techniques? Well, if you cultured this one was a different mycobacterium. It's Mycobacterium marinum, which is associated with exposure to contaminated marine water, and it grows only at 30 degrees, and so we did molecular techniques and culture techniques. The culture grew after 12 days, but the molecular techniques we got within 6 hours. And this one is a Nocardia species. Again, Nocardia takes a little longer, and it grows about 8 to 10 days, but you can do molecular techniques for within 1 to 2 days, you can get that results. So thank you.